Welcome everyone. Thank you for joining us in today's webinar. My name is Angel. Today, we will be presenting Deployment of Electronic Patient Record, Key Factors for Success by Professor Philippe Kolh. But before we proceed with our discussion, let me introduce first our speaker. Professor Philippe Kolh is the CIO and Chairman of Medical Economic Information Department at Liège University Hospital in Belgium. He is a scientist, university hospital administrator, and physician with strong experience in IT, biotechnology, and bioengineering. He has served on several scientific advisory boards in life sciences and in IT. He is also an author of 190 publications in peer-reviewed journals and has given more than 200 international lectures. In addition, he is a member of HIMSS Board of Directors and of the Governing Council of HIMSS Europe. So just a little housekeeping before we get started. If you have any questions during the webinar, you can enter your questions into the questions pane and click send. The presenter will be answering questions after the presentation. Recording of today's webinar will be available at the IHF website. So now, without further ado, we will turn the time over to Professor Kolh. Professor Kolh.
Good morning, everybody, or good afternoon. I hope you hear me. So I will discuss the deployment of the electronic patient record at university hospitals and what are the key factors for success. So the speech outline is first what was the context at a hospital, briefly located and detailing how the hospital is composed of. Then I will discuss with you the 7 success factors for the EPR implementation. That's the topic of the talk of today. And then some conclusions. So we are located in Belgium, in Wallonia. You may know that Belgium, about 11 million inhabitants, has 3 main geographical regions. The north is Flanders. In the middle, we have Brussels, which is a town, but also it's a capital, but also a region, and Wallonia on the south and southeast. And the University Hospital of Liège, the red circle, is located in Wallonia and is actually the only academic university hospital in Wallonia, the other academic hospitals being located in Brussels and in Flanders. We are based on 7 sites, about 900 beds, physical beds, 3 of which are hospitalization. And before 2004, our IT was composed of centralized administrative solutions with a lack of centralized clinical IT solutions and no IT solution from appointments on paper. So the clinical information system was obviously very fragmented. There was no electronic patient record, and the appointment system was on paper, which is very improper for multi-site organization because any patient had to call the different parts. If, for example, he wanted an appointment on one side, well, he would have to call this side in particular. Then in 2003, so about 14 years ago, a strategic plan was launched, an institutional strategic plan, and the deployment of the EPR, the electronic patient record, was a key component of this strategic plan, being sure that enough human resources and also investment resources budget was allocated to. 10 years later, so 4 years ago, our CEO changed. We had the same CEO for 11 years. And so we had a new CEO, very dynamic person named Julien Compère, and he is supporting further IT progress quite intensively, really further deployment in the EPR and placing the patient at the center. So let's go now to the success factors. The first one you may have already understood from the beginning of the presentation, being the management support, the general management support. So from the board of directors, from the CEO. And the reason is because the deployment of an electronic patient record contributes to numerous objectives. For the patient, optimal care quality and less medical errors. It's obviously very important. For the staff, it's a unique definition of data, which is important when you work on several locations, with clear procedures, improved working conditions. For the institution, it means more efficiency. So therefore, among investment priorities, it's important, it's really at the center, with human resources dedicated and institutional guidelines are imposed on users for the adoption of the new IT tools. So the management support is very important because a project like that, there are a lot of changes, it needs a lot of investments, and it's important that everybody is fully online and there is full support from the management. The second key factor is the reorganization of IT infrastructures with two strategic structures, one being the department board, composed of each operational structure head and chief sectors, with a role in strategic monitoring of information management department, monitoring of projects, IT budget management shared. And then there is a commission which is enlarged to the CEO, the CMO, the President Medical Council, the Dean of the Medicine Faculty, the CIO, myself, the Assistant CIO, the operational structure heads, representatives from the users, external IT experts, and the role of this commission is to prioritize IT projects in alignment with the institutional strategic plan, to monitor planning, and to give the green light in principle to start projects in the strategic IT plan. So this organization actually does optimize the support of projects and the adherence to their planning. The third one was progressive and gradual implementation of electronic patient record, going from the most easier part, result server, to the most complex one, which is the computer physician order entry, including for the medications. So the first step was the deployment of a result server with access to clinical biology, medical imaging, nuclear medicine, pathology, access to imaging by outside doctors. Then the second step was the implementation of medical record in a paperless mode. So we do not produce any paper chart. Everything is all the documents are scanned, produced when they are still produced in paper form, with integration of medical devices to the EPR. We have also access to a regional network, which is called the Walloon Regional Network, where all physicians that have a therapeutic relationship with a patient from various hospitals can have access to the system. We can use it for data analysis. So, for example, you can see that all data that are introduced in the EPR is identified, all zone is identified with a key, which is then inserted into or actually sent to a database, and this is analyzed by the service, the Department of Medical Economic Information, and it can be used for management, for publication, for resources allocation, for a lot of things to produce indicators for the patient. Part 3 is the resource management, the management of resources, with management of multi-site patient appointment and management of beds in real time and forward planning. Then we go to drug order and administration, with integration of a new pharmacy robot and computerized medicine cabinets in care units. This is the only part which is not fully done. We have deployed about 2/3 of these drugs. And what is important to reach level 6 is drug interaction with other drug, with allergy, with gender, with weight, with laboratory results, such as, for example, renal insufficiency. And also cross-matching at the patient bedside, which must demonstrate the 5 rights: the right patient, the right drug, the right time, the right dose, and the right route. Step 5 is the order of clinical biology and the medical technical exam. So, for example, to order analysis of blood, or CT scan, or MRI, nuclear medicine exam, or a consultation specialist opinion. Step 6 was the care management. This is the nursing chart, the nursing care program, standardized care plans, generation of interposed reports, parameter sheets, wound management protocols and sketches, whiteboards in care units, integration with monitors in ICU. And this is important. We have deployed almost everything. We have still the OBGYN to do, so 1 unit only. It obviously addresses a huge amount of agents, close to 2,000 nurses, so it's quite huge. So as I said, for this third part, the gradual implementation, the logic of this implementation was to start with a frame. This frame was the result server, the medical file, and then go to implementation of computerized appointment management. And in parallel, to support implementation of institutional clinical IT with paperless mode, mobility in care units, and peripheral functionalities. These are drug entry and nursing chart. So we are about here in the project, or we actually a little further. You can see that we are still deploying part of it, but mostly is done. The project management is also important here. It's important for a careful planning of the project for each part, validation and support throughout the project, steering committee with the deployment without sinking, and allocation of necessary finance and human resources. The fourth element is the IT architecture. Obviously, this is quite important. So we have an the implementation of the medical record that has been done in all wards, both medical and surgical wards. And some specific software that the EPR cannot substitute are allocated to a specific interface, to a specific software, which will be interfaced to the EPR. We integrate medical devices. So as I said, the objective is to have one single institutional patient record in order to optimize patient care, which should always be our goal, is the optimization of patient care. The fifth one is the involvement of users. So the implementation of each part is examined and prepared prior to the deployment with working groups, with representatives of doctors, secretaries, nurses, paramedics, according to which part of the project we are in. Each implementation has been rigorously planned and supported by field referees. So we do organize on a, let's say, 3 monthly, so every 3 months or 4 months basis, a user group meeting, which are quite rich exchange field during and after the project deployment. The steering committee, which follow the project, would meet every 3 months, would endorse the proposed schedules, make remarks and proposals, and support the project and exercise functional authority necessary to manage prospective conflicts. The sixth success factor in our mind is the very important implementation of training and support structures, which is quite important. So the financial resources provided by the hospital was not limited to technical investments, but we also do have training structures, a team of 7 people, which we call the accompagnator. So these are the people that provide training, They do the parameterization, but also the training, the teaching for all users at any stage of deployment in 2 training rooms on 2 sites. So they provide setting of the software, they provide functional support for users, and they provide also the management for access rights. We also have a team of computer scientists, about 9 people, that provide application support, and we have a team of 11 persons, 11 physical persons at the technical help desk responsible for computer equipment, but also technical help desk. So this slide's interesting. You can see that we have 3 teams, one for technical help desk, 10, 12 people, application support, about 10 people, and functional support, about 7, 8 people. So really in contact with the user, the end user, you would have 27, 28, up to 30 people that are in contact with the end user. And the last one is ergonomics. The ergonomics, there is a possibility of integration of information in EPR, which is essential. For each part of the project, there has been a needs analysis which is carried out in collaboration with relevant users. The tests are conducted during a pilot phase and are subject to validation before deployment. So we have fixed, meaning wired PC in all care units, outpatient clinic rooms, operating theaters, and secretary offices. So the idea is really that when someone needs to have access to a patient record, he or she will have access to it. Now in care units, we have mobility, so we have wireless, we have cards, as I say, Wi-Fi everywhere, laptops on trolley for medical round and nursing record, and PDA for cross-matching function. So there are mainly 3, let's say, ways to access according to what is being used. We have wired fixed PC, we have laptops on trolley connected through Wi-Fi, and we have PDAs for cross-matching functions. So it's an example of the trolleys, first generation trolley that can enter the room. You can see that on the right part of the slide with the patient and some physicians and nurses. So the physicians and the nurses, they can access the information. So this is a lecture mode, but they can also end information. They can provide prescription. They can add the daily note. The nurse can also add the daily note. And I think this is a very efficient way of working at the patient bedside. It's also possible, obviously, to turn the screen and show, for example, the results of an exam, like a chest X-ray, for example, to a patient. You can see here examples of nurses' trolleys that are designed to be linked to the medication chart. They can enter it into the room, or they can stay in the corridor. For the PDA, it's very important for the cross-matching, for example, for drug administration with a closed-loop medication administration. So this is a requirement for level 6 for at least 1 unit. At the patient bedside, an identification of the patient with the barcoding on a wristband, and the barcode on each unit to be able to demonstrate this is the right patient that is receiving the right drug at the right time with the right dose through the right route. The PDA is also used for blood sample management, so the system will associate the patient with a tube. If it's a wrong patient or wrong tube, like you take, for example, a tube with heparin, which is supposed to be citrate or EDTA, the system will say this is not correct. So again, it's very important for patient safety. You obviously can understand that this question of safety is very important for blood product administration. So it's extremely important that the nurses do the cross-matching between the patient identity and the blood product, being red blood cell, fresh frozen plasma, or platelets that are administered to the patients. you can see we have printers for this barcode. Obviously, they are in each unit, otherwise it wouldn't work. It would be very time-consuming to go to a central park. So ergonomics is a key factor. So as a conclusion, I think that setting a complete EPR has a direct impact on patient care. It provides access to a secure single record for everyone in real time throughout the hospital. It contributes to procedure standardization, to the preparation of order models and interaction, decision support. It is done through cross-matching procedures. It does prevent redundancy. For example, if I have ordered an exam yesterday, well, I can directly check into the system today whether I actually order it correctly and whether it has already been analyzed by, for example, the medical imaging department and the patient has already an appointment. It does contribute to the coordination and continuity of care. So it's a quality approach. It helps improving organization. Really, the deployment of a full EPR will show where there are problems, and they will make sure this problem come out and that we have to solve them. Some reorganization may be needed. It does reduce waiting times, and so therefore allocated better resources and also contribute to decreasing length of stays. And it's an improvement of communication with the outside being the physician, the general physician, the general practitioners, or specialists outside the hospital, and progressively the patient himself. So the hospital EPI is one of the bases for establishing an integrated care network contributing to the continuity of care for our patients. Some institutions struggle to achieve a complete implementation of the EPR, so we thought it was interesting to share our points that allow us actually to reach HIMSS level 6 on a scale from 0 to 7, so we have one more step to go. So the objective of conversions for clinical information system within the hospital is key. The support of the general management is key for investments, for human resources, for institutional guidelines to support EPR adoption. We need an appropriate organization of IT structures to oversee the EPR project. We need careful planning with division of project in different parts and to phase them. It's important. You probably cannot deploy everything at the same time. To do that, some institution may choose that, but it's very difficult, and you really need a huge team, and it's a big bank, but a big bank with both the server, the result servers, the medical chart, the nursing chart, the physician entry may be complicated. You need involvement of users. This is key. This is one extremely important. And we need working in paperless mode in parallel to the EPR. This is another key. Otherwise, you get duplicate systems. You get information into the nursing, into the medical chart, paper, and you would get a lot of information in electronic, in numeric form. So this won't work. You need mobility with a Wi-Fi through the hospital and computer hardware selected after analysis and tests. And we need to involve users. And to involve users both in the process of the thoughts, the preparation, but also with structures of training and support. And so we're very happy to reach level 6. And we actually organized this week, last Tuesday and Wednesday, a summit, a symposium, a summit with HIMSS, with the University of Liège, which actually celebrated its 200-year birthday, and the hospital, which celebrated its 30-year anniversary. And we used the continuity of care maturity model, which goes further than the MRAM. As I said, the MRAM is the electronic medical record adoption model, which assess the maturation of the system within the hospital, within an institution, while the CCMM goes outside the hospital, goes to the community, and really does place the patient at the center. So we were very happy to work hand-to-hand with HIMSS to reach this level 6 and to actually obtain our level 6. This is the end of my presentation. Thank you very much for listening. I hope I was clear. I hope that you learned something. I will be very pleased to answer your questions.
Okay, thank you, Professor Kolh. So now we will go ahead and take some time for questions. Just a reminder, please type your questions into the questions pane and click send. Okay, so it looks like we have a few questions to ask. So, Professor Kolh, what were the most significant challenge or challenges you encountered in the deployment of your EPR?
Well, let me come back a few slides. I think the part that here are really important. So I have to say that we probably did not encounter too many problems. It really went quite smoothly. One point was that at some point where we were close to the full paperless is that some physicians were very few, maybe 10, 20 out of hundreds, out of 500, 600, 700. A couple of them were really unwilling to move paperless, and we really had to say, no, you have to move paperless. We're going to help you. We're going to design, you know, maybe drawings or whatever is needed for you, but there cannot be any exception. I think it is key that we do not have any exception for the use of the medical chart. The second one is when you move into the cross-matching, the nurses are usually reluctant to use the system with a PD at the beginning, not because it is complex. Obviously, the system has to work. You need a full good Wi-Fi connection. You need a system which is ergonomic. You need an application which is easy to use. But the only reason is that they would tell you it takes time. This is true. It does take some time. But altogether, it's maybe 1 minute, 2 minutes to do everything. But at the same time, it does improve patient care. For example, for the administration of drug, the cross-matching, it does decrease the number of errors. And when you implement the system and we actually measure the errors, you will see that the system, the cross-matching, will decrease the error. So sometimes you get a little problems with adhesion of the people, because they don't like change, so they're reluctant to change, and also because they think it's somewhat time consuming. Those are probably the most, let's say, inflammatory, difficult part that you would encounter, I would say, to answer this question.
Okay, so another question is, what is the annual budget that is allocated to IT in your hospital?
Well, I think we have to answer this question dividing into real money for investment, to buy things, to replace things, and human resources. And both should be linked quite closely. For the first part, we invest about 3 million euro every year since 2003. 3 million euro is about 10, 15%, sometimes a little less, of our overall investments. So every year, there's a significant amount of money that's injected, that's used in IT, and in particular for the EPR. A lot obviously would be into the hardware, into the servers, into the computers, and so forth. Part for software also, but a little less. But human resources are also very important. So every year we hire probably 2 or 3 additional people, and there should really be a link between the two. So 3 million euro yearly and additional resources every year.
Okay, so another question is, how did you organize user involvement?
Well, user involvement is through working groups. At the beginning, especially for each part, I divided the project into 6 parts and even subparts. it's really key to ask for every medical department to have representative, at least one per medical department, one doctor, one nurse, one secretary. And you put them together, it depends according to what they do, and it's important to analyze what they need. So these are working groups, and then after that, when we progress into the deployment mode, to have a user group meeting 3-4 times a year, so every 3-4 months, where you show what you've done, and you ask them questions, you ask them the feedback. It is very important at the beginning of functionality to assess it, to say, okay, we are at the beginning, we are in a pilot unit or 2-3 pilot units, and then we say, okay, are you happy with the pilot? Yes, okay, we can move full speed and we can deploy full speed. So both at the beginning through working groups that would help to define what we need to do, what functionalities need to be put into the software, and throughout the process to get feedback from them.
Okay, so we still have time for more questions. Please type them into the questions box in your control panel. Okay, so did you get help from external expertise like change consultants?
No, well, not really. What we did, if I go back to the second key factors for success, if you remember, is the reorganization of IT structures. So we did it, and we were helped by the former CIO of the university. So the hospital and university are two different entities, but they work very closely hand-to-hand together. And what we did is to hire the former CIO of the university, which actually had retired. He was just over 60 at that time, and he helped us during about 2 years to reorganize the IT department, to develop the IT department, to really define and prioritize the missions. But there was no real help, or very few, in terms of the concept of the project. We used people that were inside, that are still together. Actually, it's still a team around me. We meet about every 2 weeks, and then we progressively hired people, but there was no full external audit.
Okay, so for our last question, among the 7 success factors you developed, which was, in your opinion, the most important one?
I think there are 2. It's the general management support. It has to be an institutional project. Everyone has to be online, on board, on the ship, no other direction, human resource dedicated. This is one. And the second one, which to some extent you can see it in a mirror, is the question you ask, Angel, is about the user involvement. You have to do that with the people that are using the system. You cannot do it without them. You certainly cannot do it against them. You have to convince them. I mean, a lot of them are willing, obviously, to be on board naturally. Some need to be convinced. So really need to get to work with people, hand to hand with them, and what they will do it if they are convinced that it's actually an improvement in patient care. We are a hospital, so the physicians, the nurses, the physician therapists, the logopedics, the secretaries, the medical secretaries, to us all wants to work to improve patient care.
Okay, so it looks like we had covered all of our questions, Professor Kolh. Is there anything else you wanted to cover before a wrap-up?
No, I'm very happy to be able to present that, to have been able to present with another aspect what we have done into more details at a meeting of the International Hospital Federation last year in Durban. It was a very good meeting, and happy to have been invited to give this presentation through this webinar, and hope to have more collaboration with IHF in the future.
Okay, great. Thank you, Professor Philippe Kolh, for sharing your valuable knowledge with us. Thank you, everyone. We appreciate you being here. The recording of today's webinar will be available on demand at the IHF website. Attendees will also receive an email with a link to view the recording of this session. Thank you again for joining us today, and we will see you next time. Thank you.